instructions.
Right. So thank you, Danish. So welcome everybody for today's, I think it's day 5. We had very successful and useful and fruitful discussions in all the sessions. They had really been very spirited discussion, very helpful case presentations, and different angles of managing the different topics, different angles of managing the COVID-19 disease. So today, so let me just introduce some of the rules that you will have chances to put the chat box or Q&A, and I will take them in the order that I will receive them. And then after the short presentation by Dr. Kaleem, then we will start, answering those questions. And so please continue to write your questions in the chat box and Q&A so that we can get to them. And we'll try to finish today by 12. So far, we've been going over. And so maybe if there are pressing questions, we may go over 5 minutes because there's a delay of starting in 5 minutes. But other than that, I think we will answer those questions tomorrow. So if some questions are left unanswered, please check back tomorrow. You can join, or even if you will not be able to join, you can approach the recording of this session to see your answers. So with these, I would say, and also if please introduce yourself in the chat box, as well as afterward when the panelists start discussion and questions, or other people, if I'll ask them to present their question, please introduce yourself if it's your first time, or even just introduce yourself briefly and then ask the question. With that, I will invite my friend Dr. Kaleem Ahmed, who is a pulmonologist, intensivist, as well as sleep specialist. So he has 3 boards and a very busy practice in Meritus Hospital in Hagerstown, and now in Frederick as well. And also Kaleem has been a very active and very long time member of Merit, I think over, I would say 8, 9 or more years. And so with that, Kaleem, please introduce yourself. If any other, I think you are from Dow and the year, and then you start your presentation. Thank you for speaking up.
Thank you very much, Shahid and Merit, for providing this opportunity. I think I'm enjoying and learning as much. I think I have not learned this much regarding any topic since we started this Merit COVID project. And I think it's a wonderful opportunity. As you already introduced me, I'm from the Sindh Medical College. And I graduated in '89, and I am practicing in the private practice with pulmonary critical care and sleep medicine. I had the privilege of visiting Pakistan several occasions through the APPNA Merit and visiting faculty programs, and I've seen firsthand what kind of challenges we are facing in Pakistan. So that helps me a little bit in terms of finding how to improvise those things and how we should help each other in terms of dealing with this pandemic. So without further ado, I'm going to start my presentation. Today, I'm going to talk about people who are joining this forum. We have discussed over the last 4 days almost every angle of the COVID-19, and most of the issues which we are facing all over the world has already been discussed. My objective today is to provide a guideline, which is not my guideline. It's a guideline which is published by Surviving Sepsis Campaign. And these guidelines are primarily focusing on how to take care of the critically ill adult population with COVID-19 in critical care setting. So this article is recently released on the net on March 27, and it has undergone peer review and been accepted for co-publication for both the Journal of Critical Care Medicine as well as Intensive Care Medicine. But definitely, this manuscript has to go through some other fine-tuning before the final publication. But anybody can go to the net and look into their this publication and learn from their guideline. So what they have done is, because medicine is evidence-based, and that is what we cherish. But when we deal with a condition, what we are dealing right now is a pandemic, which people have no idea what exactly bug war and how we to handle this thing. So people who are expert in critical care medicine, Surviving Sepsis is the biggest name, and most of their recommendation considered as one of the fundamental guidelines for the management of critically ill patients. So these people have gathered about 36 experts from 12 different countries, and they propose 53 burning questions relevant to the management of COVID-19. And primarily, this guideline provides recommendation to support hospital clinicians who are managing these patients in ICU setting. And when they were compiling this thing, they tried to balance it with the vast majority of the people who are different income settings. So not only the people who are very privileged in the first world countries, but also in the our third world countries as well. And again, these are the guidelines. It doesn't mean that you cannot deviate from that. And when you see the recommendation, you will see that we're already deviating from their recommendation, but that's okay. We can have a healthy discussion on that. So these guidelines divided into 4 different categories, starting with the areas of infection control. Then it goes to the lab diagnosis briefly, and then all kind of supportive care, which is critical care, is primarily a supportive care management. And the 4th one is therapy. And we know that there is no documented therapy, and we are struggling and improvising ourselves on the basis of anecdotal experiences, and we're going to go on to that as well. So first thing is infection control. These are the bullet points of the recommendation of 51 recommendation. I have highlighted those things and put it into these simple statements. So the first one is the healthcare worker, when they are performing aerosolized generating procedure. And what does it mean by aerosolized generating procedure? Any procedure which has potential for generating aerosolized from the patient to mouth and nose, including endotracheal intubation, bronchoscopy, open suctioning, administration of the nebulizer treatment, which is very common, we all use all the time. Manual ventilation before intubation, very important. A lot of time, traditionally, when we intubate any patient, we try to pre-oxygenate by umbu bag and try to maintain the oxygen to a certain level. This thing is very dangerous in COVID patient because it is going to create a lot of aerosolized particles. And in fact, the current guideline from the anesthesia from Fred is they are avoiding this thing. And the physical proning, a lot of talk about the proning of the patient to improve the oxygenation, and disconnection of the ventilator, doing non-invasive ventilation like CPAP and BiPAP. In the later stage, when the tracheostomy need to be done, or cardiopulmonary resuscitation if somebody is not responding to the supportive care. All these procedures, when somebody is performing, it should be healthcare worker who are doing this thing, they should be using N95 respirator. Everybody knows that this is in short supply. And that's the reason I'm stressing this part, that this recommendation is only you can use this thing if you are exposed to this environment. Otherwise, you have a different type of recommendation. In addition to that, definitely all the PPE, which eye protection, gown, gloves, and face shield and goggles, if available, need to be used. If performing aerosolized generating procedure in ICU, negative pressure room should be used. Now, this is a big thing. We are talking here for our colleagues and co-worker and friends in Pakistan. I know firsthand there are a very limited number of negative pressure rooms. So what should we do? We cannot follow this guideline because we don't have, even in the big center, we don't have these facilities. So I would recommend going to the WHO website, looking for their open ventilation policies and guideline, and a lot of organization and institution who has experience in terms of dealing with TB and TB related ventilation system. I think we should take their experience and incorporate in current environment. If somebody is providing usual care on non-ventilated patient, surgical mask and medical mask is sufficient. This is a weak recommendation, but this is on the basis of science. There was a study done and published in JAMA on the healthcare worker in 2009 in Toronto, about 1,000 healthcare workers who were taking care of the seasonal influenza, and they tried to compare N95 mask with the surgical and medical mask and try to see what is the seropositivity among the healthcare worker. And the medical surgical mask has shown no negative comparison compared to the N95. So this is an extrapolation of data. I cannot say that this is compatible with the COVID-19, but this is the best what we have. So that's the reason they are recommending that surgical mask in non-ventilated patient should be enough. Performing aerosolized generating procedure on mechanically ventilated patient in a closed circuit. Again, this is a keyword, closed circuit. I know in Pakistan, there are many challenges, even with the center where they have ventilator. They do not have closed suctioning catheter in most of the places. The humidifier, sometimes they don't use. I mean, they don't use humidifier, the chances of that circuit is broken is very high. Even the expiratory and inspiratory filters, which is, we take it granted here in US, those are not used on a regular basis. Even the tubing, which we have to change every time we're changing the patient, they were used on different patients. And I'm talking about my personal experience. I don't want to name the institution because somehow I have seen in several different institutions. So it's a challenge. Our colleagues who are performing these frontline work, they are aware of this thing. And if they're not, please talk to your technician, technologist, and make sure that what these recommendations are on the basis of a standard of care on the guideline of the ventilator and how to manage and how to put the patient. But if it is not followed properly, we're going to defeat the purpose. So even in that kind of thing, surgical mask is going to be enough in addition to your own gloves, gowns, and other PPE. For endotracheal intubation, they suggest that if we have video guided laryngoscope, that should be used. Some centers do have this, but not everybody. And the other thing is that healthcare worker who is most experienced in managing airways, like here, anesthesiologist teams are being made in all different big organizations and institutions, and they are the one who should be taking the lead in terms of intubation. The whole idea is that we should minimize the number of attempts, and in other words, try to minimize the aerosolization of those COVID-19 to protect the co-worker and the environment. Laboratory diagnosis. Again, for intubated patient suspected of COVID-19, it is recommended that the lower respiratory tract sampling endotracheal aspirate should be used instead of nasopharyngeal or oropharyngeal sample. And why is that? Because the sensitivity of nasopharyngeal and throat specimen is about 65 to 70%. So you might have seen a couple of colleagues have shared their experience that there are patients who are suspected to COVID. They did this sampling, it was negative, but because the clinical picture was so compelling that they decided to treat the patient, and then repeated testing third time, it came positive. The good thing is that there's no false positive with this, only false negative. So if you are intubating a patient, take the endotracheal aspirate. Again, endotracheal aspirate from the catheter. If it is inline seal system catheter, not opening the ET tube and then trying to perform that thing. These are the things you could implement by talking to your suppliers, your managers and colleagues, how to get these equipment if it is not available. Because otherwise, we're going to defeat the purpose of controlling the virus in our healthcare environment. Supportive care, this is the big one. That's what we do in intensive care. Supportive care is the critical aspect of the management. In COVID-19 shock, dynamic parameters of patient is more important than any static parameter. What does it mean by dynamic parameters? So dynamic parameters like skin temperature, capillary filling time, or serum lactate measurement to assess the fluid responsiveness. And again, fluid responsiveness doesn't mean that we have to dump 3 liters of fluid as we sometimes do in the sepsis. This is not the time, and a lot of times this has been already stressed, so I'm not going to detail. But if you are managing a patient, check their capillary refilling. If it is less than a 2 seconds or more, it means that there is some chances that the patient is not having a good cardiac output. Skin temperature is also the same way. Straight leg raising, maneuvering to see the map change or not. Monitoring CVP alone or map as an indicator, these are a static indicator. These are not as helpful. They could provide a good guideline in the future management or ongoing management of the patient when you know the baseline, but not as an initial assessment. For accurate resuscitation of the shock, it is suggested that conservative over liberal fluid strategy. So there is a 2 strategy. A lot of time we already have discussed about this, that not try to give too much IV hydration to these patients because ARDS and wet lung will cause more problem than good. Conservative and liberal, it is a tricky thing. And overall, the amount of the volume which is supposed to be given over 1 to 4 days and 1 to 7 days is varies. So New England Journal of Medicine in 2006, there has a randomized controlled trial. Majority of that trial looking for the conservative and liberal was meta-analysis. And the meta-analysis has a different way of in terms of looking things, and standardization of the parameters is not as great. So basically, if it is within 7 days, but around 2 to 4 liters of positive balance versus liberal fluid strategy is about 9 to 12 liters of positive fluid balance. And so one has to try to keep it as conservative as possible. When you're giving fluid, we always give crystalloid over colloid. So crystalloid fluid has normal saline or ringal lactate. And even in the crystalloid fluid, the buffered balanced crystalloid solution like ringal lactate should be given if available compared to the normal saline. And there is a strong recommendation not to use the starch of dextran, which I remember still in Pakistan in some institution, they use these volume expanders. So these things should be avoided. For patients with shock with COVID-19, first, if the patient is still having shock with the fluid resuscitation, then starting non-epinephrine, which is lever-fed, as a first line of vasoactive agent. If the non-epinephrine is not available, then one can use vasopressin or epinephrine as a first line agent. And there is a strong recommendation not to use dopamine as a vasopressive agent in shock with COVID-19. If using non-epinephrine and using it as a dose of 10 or more microgram per kg per minute, if person is still remaining in shock, then instead of increasing the dose of non-epinephrine, it is recommended to add a second agent like vasopressin to take care of the shock issue. The target MEP, mean arterial pressure, should be managed around 60 to 65 rather than higher than that. And despite of using all these, and if still patient has evidence of cardiac dysfunction and persistent hyperperfusion, despite of norepinephrine and fluid resuscitation, then adding dobutamine instead of increasing the norepinephrine should be preferred. And then this is a controversial thing. There's a lot of talk about the using of low-dose corticosteroid. Well, look, if every measure is failed and the patient is still in shock, the studies which is done has shown that adding on to the low-dose corticosteroid, which is around 200 microgram hydrocortisone, either in divided doses or continuous infusion, has shown some benefit. And majority of the panelists, not all, but majority of the panelists of these guidelines prefer using that thing in septic shock as a, shock reversal agent. Now come to the ventilatory support. So in critically ill patient with COVID-19, the case, about 49% people, it's a mortality, and the higher mortality has shown more than 50%, and some reported showing that it's about 60% or so with patients who are ended up on the mechanical ventilation. Again, this could be difficult to assess because there's multiple different variables which play a role here. But to stress a point that this is a serious medical condition, and you have to use all the tools that you have available. Prior to intubation, supplemental oxygen should be started in anybody who has significant hypoxia, and the strong recommendation is to use oxygen if the SpO2 is less than 92%. And try to maintain it around 96% instead of higher than that. In acute hypoxic respiratory failure, if person is still having problem with the oxygenation, then high flow nasal cannula should be used if available over the conventional oxygen therapy, because the conventional oxygen therapy only goes up to the certain liters depending upon what equipment you are using in your setting. And if you have non-invasive positive pressure ventilation available and high flow, prefer high flow, because again, the non-invasive positive pressure will have a problem with the aerosolized generation. So that is the only reason, not because of something else. If high flow is not available, then you can try a non-invasive in a controlled environment, and early intubation is the key. so that you can use all the precaution and all the team which is you have made, use it to minimize the aerosolization. And this is some guideline. I think 2 days ago, somebody also has shared this thing during question and answer session. So basically, indication for intratracheal intubation is there, you do it. And if it is not, then supplemental oxygen to continue, then high flow nasal cannula oxygen should be used. And then, you know, as a rescue, a trial of an IPV should be done. But otherwise, this is basically going through the, depending upon what kind of condition patient is in. So I'm not going to go into detail. You already know about this thing. We talk about that. Invasive ventilation, you know, one of the most important breakthrough happened in management of ARDS patient is from ARSNet study. There are several different modalities of ventilation was used, and there are in the big centers, new ventilator, there are many different modes of ventilation is available. The only thing has shown significant mortality benefit is the conservative management of the tidal volume and the pressure. So, and this is the data coming from there. So from the ARSNet study, and also in the COVID, keep the tidal volume between 4 and 8 millimeter per kg of the predicted body weight, and try to avoid the higher tidal volume. This is in this recommendation, there are only 5 of the strongest recommendation, and 3 to 4 of them was from the ventilation and oxygen related recommendation. So they are very confident that this is a standard of care. And the plateau pressure, we already mentioned many times that try to keep it less than 30. And the high PEEP strategy or the low PEEP strategy. High PEEP strategy usually is more than 10 centimeter of water. And in the median, the study which was report coming around 15 and up is the mean PEEP in a higher PEEP strategy has been used. And if the patient is not improving with these maneuvering and the oxygenation is still kind of pretty bad, then try to do prone ventilation in your moderate to severe ARDS patient. Now, the prone ventilation, everybody is talking about prone ventilation. I think prior to N1H1 pandemic and SARS, the data was very soft on prone. It has shown oxygenation improvement, but no mortality benefit. But since the SARS, we have seen there is significant improvement with prone, with ECMO. So the proning is very important, but doing a proning in 24-hour cycle, 12 to 16 hours. But the problem is that a lot of people are not trained how to do proning. So if you can see my slide, this is the YouTube video they have suggested to learn. This is the 5 minutes video, and you could copy and paste. I can click it just to show you how it's going to come up here. And it is a labor intensive thing. So I'm going to stop this video here. You can look at the link and try to see it in your own time. And this is basically also coming from the New England Journal, trying to teach people how to deal with this. And when you're proning, there is many different things one has to be taking in mind. That proning is a very unnatural position, and then patient ventilator dysynchrony could be a major factor, dislodgement and kinking of the ET tube, and chances of having multiple people working together, disconnecting of the IV lines. So one has to be very careful. Neuromuscular blocking agent should be used intermittently. in those kind of scenario, or in infusion up to 48 hours if needed. If despite of all these things, if things are not improving, again, for our nitrous oxide, which is they mentioned, but I don't think most of us in Pakistan will have nitrous oxide to use or any other vasodilator. But nitrous oxide use, it's not recommended on a routine thing. Again, as a salvage maneuvering for hypoxic patient, one could try. But if it is not working, you have to slowly wean it off rather than abruptly discontinuing it. And it should only be used with the specialized device connected to the ventilator. It is so basically forget about this, because probably we're not going to have those kind of facility in Pakistan to implement that. Recruitment maneuvers. Recruitment maneuvers, there are many different recruitment maneuvers one could use. PEEP is one, and the inspiratory hold is another. But when trying the PEEP, one thing they suggested is to avoid a staircase increase in the PEEP, like incremental increase. So if somebody has a PEEP of 10, go to 12, to 14, to 16. No, you go up, increase the PEEP, all of not from the stepwise fashion, but to start the PEEP and maintain there. The problem with the high PEEP, that there is always chances of barotrauma and increasing the airway pressure, depending upon the compliance of the chest. But that has to be, taken into consideration. And neuromuscular blocking also should be considered to minimize that. And then if everything is not working, then probably going to the veno-venous ECMO. And again, probably this is not going to be something which we will be looking at in Pakistan. And again, this is invasive mechanical ventilation chart, what to do and what not to do. You can take a picture of this and go over to that. This is basically summarizing what I've been telling you. Therapy-wise, there is very little suggestion from therapy-wise. Here, everybody is now utilizing different therapies, but without ARDS, routine use of systemic corticosteroid is not recommended. But if patient has ARDS, using the systemic steroid over not using systemic corticosteroid. So means that if somebody has ARDS and they are not responding, then using the steroid is preferred. Again, low dose 1 to 2 milligram per kg for 24 hours for short duration. And this is what is majority panelists supported this thing, but not all. And this was a suggestion. Data is is not very conclusive still. Using the empiric antimicrobial agent and antibacterial agent is recommended. As we know from our understanding from the MERS pandemic in the past, about 18% of the patients who was mechanically ventilated with ARDS have bacterial co-infection. And as we know that here, when we were struggling with the diagnostic kit, we were doing the influenza and viral influenza and the respiratory viruses measurement. About 5% of other viruses also are, co-infection happen with that. So giving the antibiotic, depending upon the different clinical condition, the microbial spectra in your institution, decide accordingly. But using the antibiotic is recommended in these patient population. For fever control, using acetaminophen or paracetamol, and again, there is other therapies which were used in the past, like IVIG. It is not recommended to use it in these patients. And now there is a lot of buzz going on about the convalescent plasma. I think there are discussion on the TV. Also, some doctors both in Pakistan and also in different other parts of the world, are trying to use convalescent plasma, like taking the plasma from the recovered COVID patient and the antibody which is available in the plasma, transfusing to the seriously ill COVID patient. This has been done in the past. It's been used for many different viral infections. In fact, it's available for more than 100 years. But the data is kind of very mixed. So the current data, which is we have from the China, about 250 patient COVID population, the overall in some patient it has shown some improvement. In other patients, it's not. The problem they are facing is that efficiency and safety of the plasma is limited. Target for the sufficient level of the neutralizing antibodies is also not known. There is a recent publication in the journal JAMA Net where there's Xinjiang province. I think there's a 5 patient and all of them was given convalescent plasma therapy. 4 of them was given at the day 20, 1 was on day 10, and they have shown improvement in the outcome in terms of their oxygen requirement and continued mechanical ventilation. But those patients was also receiving antiviral therapy. They were receiving ECMO. They were receiving corticosteroid. So which therapy has resulted in the improvement, we don't know. But this is the kind of limited data which we have, so we cannot say anything beyond that. Again, hydroxychloroquine and chloroquine, now I think everybody here in America is using it in the institution, especially patients who are admitted in the critical care unit. And we talk about that a lot, but so far that this data is kind of limited, and they were not recommending it. Antiviral therapy like lopinavir and ritonavir was advised against using this thing. And then the using of other antiviral agent was also not recommended. Remdesivir, there is a lot of buzz about this thing. About 2 weeks ago, the FDA has approved this thing, and there are people where the drug is available, they are using it, but there is a randomized control trial is going on to see the effectiveness of this therapy. So I'm going to stop here, and if anybody has any question and comment, I'll be more than happy to share my thoughts, or other panelists might help you understand it better. Thank you very much.
So thank you. Can you hear me?
Yes.
Okay, so thank you, Kaleem, for a very wonderful presentation. Now, we would like to briefly address most of the questions. Can we go over the questions from the last session first briefly that were not covered, and then we'll address the 7 questions that we got today. And so we'll see how many we can get to. So one question was actually basically asking from attendees that if they know, if any of the attendee know, what type of ventilator is being used in Pakistan predominantly. Does anybody know about this?
I'm not sure I could answer. I think people who are working in Pakistan might be in a better position to give us an input, because I think this question is very important to guide them.
So, Fivzia, would you know, Indus Hospital is using what kind
Well, we have a couple of Zella vents, but apart from that, we're getting in a lot of donations. So I can check out and give you an answer by tomorrow that which are the most commonly used ones that we have.
Yeah, that would be good. I see that Dr. Shakil Mirza has raised his hand. Dr. Shakil, you want to go ahead? Dr. Shakil Mirza, can you speak? You had some comment?
Dr. Mirza, you're muted right now. You'll have to unmute yourself.
Okay. Thank you very much, Dr. Shahid and APPNA for arranging all this. These have been very informative sessions. My question is about the convalescent plasma. Are there any ongoing trials in the US as well? Because we know that we have started in Pakistan, but the evidence, as the speaker said, is very limited. So any trials in the US ongoing?
Dr. Shakil, can you also kindly introduce yourself to the audience?
Yeah, this is Dr. Shakil Mirza. I'm a consultant physician, and I'm from the Army Medical College in Rawalpindi. My question is about the use of convalescent plasma. And my query is, are there any ongoing randomized controlled trials in the US? Because as the speaker said, there are a lot of fallacies in the previous trials. Thank you.
So somebody else want to take this? I don't know the first-hand information about this, but I think there are centers which are trying to do these randomized trial. I think we still have to wait and see. Logistically, one has to see that you need to have a large pool of the plasma to collect these convalescent immunity, and then you need to store in those facilities, and then so there is a multiple things which is is going to require for that. Just to share briefly about the overall outcome, what is the negative and positive outcome we have with the convalescent plasma. So there is a study published in 2014 in Journal of Infectious Disease by Dr. Ven, and that was looking at the convalescent plasma in SARS, in avian flu, in H1N1, and they have seen some mortality benefit. So odds ratio was 0.25. On the other hand, there was a randomized controlled trial done in patient with the Ebola, and they were using convalescent plasma of unknown level of neutralization. So what does it mean is you need to map out how much antibodies you're going to require for certain patient population. First, you have to do in vitro analysis, and then you have to transfuse that thing. So in Ebola, they try to do unknown level of neutralization, and the data was kind of negative study. So it has not shown any benefit of that. So when we are dealing with this kind of thing, and this is a very boutique type of treatment option, we tend to gravitate to those kind of things. But I think the important factor is that what is the most commonly available treatment, what are the basics which we can make a difference, and those basics are important supportive care. Important supportive care. Those are the basics.
Yeah, thank you, Kaleem. I think Majid has a reference about it, but I think that study has not started. Majid, you want to address that?
Oh, yes, I was just pointing out, so, good question, Dr. Mirza. Any and all active or recently completed clinical trials that involve the US, at least by definition as a requirement, have to be posted on this freely available website called clinicaltrials.gov. I posted the link to that as well. So as you asked the question, I just went ahead and typed up convalescent plasma. And although I couldn't find a currently recruiting trial on this. I am aware, though, that at least at some centers, particularly in New York State, it is already being used, and we're hoping to use it in Massachusetts as well, where I practice. But it turns out that at least in Mexico, they already have a full-on study planned for this, but it hasn't started recruiting.
Thank you.
You're welcome.
All right, so I will again now go back to the, like I said, from yesterday, one more question that was not covered actually was about this convalescent plasma. So I'm glad that we covered that. The next one was, have you used the mode of therapy? And what is the experience? So I think it's related to the same plasma therapy. The next question is, what is the sensitivity and specificity of the serological finger prick test? So anybody can take that.
I think our ID folks might be able to help because this is what I think I asked yesterday.
Sajid is there. Sajid, would you like to take it?
Assalamu alaikum. Can you hear me?
Ji. Go ahead, Sajid.
Ji,
Introduce yourself. So Sajid, Dr. Sajid Chaudhary was our first speaker, and he's the ID specialist and chair of medicine in Orlando, Florida. Go ahead, Sajid.
Actually, I'm not aware of the sensitivity of these newly approved tests because it's not being used at our institution. We are still doing the PCR, and the sensitivity for the PCR is about, I think, is 70%, 70+%. I'm seeing a lot of patients actually who are PCR negative from the nasopharynx, but highly suspicious clinically, and inflammatory markers suspicious for COVID-19 disease. Two of them, they eventually deteriorated and got intubated, and then the tracheal aspirate was positive. So what I'm hearing about or reading about the test is like about, I think it's 50% sensitivity for that newly diagnosed, FDA approved, newly approved by FDA test. But the PCR is actually, we thought initially that it will be close to 90+%, but it is about 70%. And right now I have at least 4 patients. I'm keeping them on isolation and treating them. They're negative by PCR from the nasopharynx, but they are stable, but they're highly suspicious for COVID-19 disease.
So thank you, Sajid.
I can quickly add, I think the one that FDA approved was the test that was developed by the company Celex. And at least some preliminary data suggested it had around a 90% sensitivity and specificity, but that's really based on very limited data. So we'll just have to see.
Okay, great. Now, another question is that, can you, Dr. Kaleem, elaborate on a negative pressure room and effectiveness? And when do you decide that the patient needs a negative pressure room?
So negative pressure room is specially designed in a way to take care of the aerosolized particle in the room and remove, I don't remember exactly, but I think it's a 6 cycle removal in 1 hour. And those procedures include your intubation, your non-invasive ventilation, nebulizer treatment, open suctioning, doing tracheostomy in patient. So all these procedures, which I, considered as high risk for aerosolization. Intubation is the biggest. So whenever there is a chance of these kind of therapy, which has potential for patient breath coming out into the environment, that has to be prevented. So बुनियादी काम यही है कि भाई देखना ये चाहिए कि वो क्या कॉमन सेंस अप्रोच इस्तेमाल करने की जरूरत है नए दौर पर.
All right, thank you. Anybody else have a comment on that?
I just wanted to ask that if we do not have a negative pressure, would it be advisable just to go on with the endotracheal tube rather than get a tracheostomy? Because you know the conditions in Pakistan, as you mentioned, we don't have negative pressure zones. We are doing what we can with HEPA, UV lights, and N95 filters. So wouldn't it be better that we go on with the ETT rather than have a tracheostomy? Then our OTs also are not equipped for that, neither are bedsides.
I think so. These guidelines, as we are now seeing, are kind of changing from center to center, and I cannot say there's no. My talk was primarily with these SSCM guideline kind of thing, so there is nothing from there. But what I'm hearing from my colleagues is that the tracheostomy guideline, with not keeping the patient more than 2 weeks on the ED2 is changing. Now people are keeping the patient longer and not jumping to tracheostomy if the patient is hemodynamically stable and on mechanical ventilation, but is still requiring higher support. Then they're keeping it on for more than 4 to 6 weeks time. Again, I think we all have to stay tuned and learn from each other to see what exactly is going to work.
All right, thank you. I think another question that, including me, a lot of people are interested to know is that these changing guidelines about the face mask, non-surgical face masks, like CDC came out with recommending that people, general public, should use masks, but then there are other information that it does not protect you from viruses because the pore size is obviously bigger than that. So what is the panel and speaker think about it at this point?
I can give you my thing that I'm very skeptical about these guidelines. I think it's on the basis of supply and demand rather than science. But I will leave it to my ID folks to educate us.
Dr. Sajid?
If you are asking about the question about regarding the
non-surgical masks, like cloth masks,
used
what
by
is the current status by general public?
Yeah, I think for general public it's okay, because general public is not, they're not like kind of coming across with the positive or highly infectious patient. It also depends upon if somebody's like actively coughing or producing the particles and droplets, and then somebody's close by. So I think for the general public, I would prefer actually have a mask when go out. But for the patients, you're taking care of the active patient with active disease, guidelines are like surgical mask can be used, but still I prefer the N95 mask with going into the patient's room. Again, I agree with you, guidelines keep on changing, but that mostly depends upon the supply and demand. Thank you.
Right, but the cloth mask, does it prevent the virus from crossing?
I think it's just better than nothing. That's what it is. All general public, they cannot have access to the surgical mask. So that's what they are recommending, to have at least covered your face. Actually, it's a twofold benefit. One is to prevent the virus if it can. And the second thing is actually, which I feel is the more important, when your face is covered, so you will not be touching, the person will not be touching their nose, mouth, or the face at that oftenly, which reflexively most of the people they do. So it actually prevents the contamination of the virus if somebody is infected.
I see a question here. Why not dopamine? Can I answer that?
Yes, yes, sure.
So again, the use of dopamine is not specifically looked into the COVID-19, but it's basically looked into Cochrane review in septic shock thing, and there is no significant primarily data on the basis of specifically dopamine versus norepinephrine as far as the modality, direct mortality thing is concerned, but there is a high risk of arrhythmias reported in Cochrane review with the dopamine compared to norepinephrine. And then by virtue of that, one could draw a parallel that might lead up to the poor outcome in those patient populations.
All right, thank you.
Dr. Shahid, may I share one
sure, absolutely
interesting case that I came across today? Maybe some other my colleagues can comment on that. A young guy, about I think 25 years old, history of asthma, presenter with the new onset of shortness of breath, dry cough, and then fever. So it's a mild leukocytosis, relative lymphopenia. Inflammatory markers were elevated, CRP about 60, procalcitonin negative, less than 0.05, and PCR was negative from nasopharynx. So when I asked him about the history, he said that he has been staying at home for almost a month. So just for your information, we started seeing cases about 3 weeks ago in Central Florida. So this is the first time he came out of home. To come to that, if it is a false negative. So then I asked him, do you smoke? He said, no. Then I asked, do you do any vaping? He said, yes. So he had the interstitial infiltrate on the lungs, low-grade fever, mild leukocytosis, and cough, dry cough with shortness of breath. So now dilemma whether we should take him off isolation and just label it as a vaping-induced injury, or just keep him on. He's still on isolation. I just kept him to see the inflammatory markers by tomorrow. So I just wanted to share that vaping-induced lung injury presents clinically and radiologically exactly the same way that we're seeing the COVID-19 patients.
Yes, yes, it's a challenge, and a lot of people, last year, if you remember, in the midsummer, these case reports and young people are coming with this thing. So it's going to be difficult, but I think in current environment, I think keeping the caution on the side as you are doing is the right approach. I don't know, there's no right or wrong answer, but this is the way I would approach it.
All right, so I think we are coming to the close of the session. Let me double check if there was any more question in the chat. I think one question that has come up is that for prone ventilation, because there's a lot of recommendation. Are there any special beds for that?
Yes. So there is some companies in our institution. We have 2 prone bed, which is easy to handle, but you don't need these special bed for doing the proning. As I shared the video, if you go to Sepsis guideline, it's there. I can share you again that Let me see if I can share the screen here and give you the video link. No, not this. Okay, go. So this is the video link. This is a 5 minutes video on the YouTube. These are basically given by the sepsis survival team, and it is also, so you can see that you need at least 3 to 4 people, and there's a, if you have not, somebody has not had experience in doing it, they need to watch it carefully, because if you're not going to do it properly, you're going to do more harm to the patient. But the short answer is you don't need any special bed, but you definitely need a very significant understanding, which is not difficult, but you need to watch this thing and you will learn it very quickly.
I think this would be the last question. Any role for carbon dioxide tidal volume? I'm not sure.
I think, if I understand correctly, I think probably the questioner might want to know, when we are doing the lung protective strategy, sometimes because of the low tidal volume, the CO2 retention happen and patient develop acute hypercapnic respiratory acidosis, which we, in our term, use it as a permissive hypercapnia. So you can tolerate higher PCO2 to maintain lung protective strategy. It has shown much more benefit in terms of keeping the lung protective strategy and swallowing the higher PCO2 and some acidosis.
All right. Thank you, Kaleem. I think we will close this session today by thanking our speaker, Dr. Kaleem Ahmed. Thank you for a very pertinent guidelines and all the time that you have. And thank you for our panelists today, as well as the attendees. What we are trying to do is to start the session at the time. I know people are joining slowly, but I think if they know that we will start the session right at time and end at time, then it will be helpful. So until tomorrow, again at 8 a.m. in Pakistan time and 11 p.m. Eastern Standard Time. Thank you all. I really appreciate everybody's participation. Thank you. Bye.
Thank you.